Hello friends, welcome to my channel Anatomy Hub. Today we will going to study about the psoas major muscle. So psoas major muscle is not a single muscle, it is a psoas major and often you will find the psoas minor muscle. So most of the consider this psoas major muscle just a hip flexor muscles. We will go detail about this muscle. So it is a very huge and important muscle complex. It is working as a one unit as a Iliopsoas. They considering as a Iliacus and Psoas acting grouply as a single axon. Psoas major muscle, huge muscle that can have different variety of actions that we will see here today. Psoas muscles differ from the iliacus in that it has a different architecture, innervation, and more importantly, a different function. The psoas muscle is comprised of both the psoas major and psoas minor muscle, but as the psoas minor is often absent in individuals, so we will focus on the psoas major muscle. So, a better understanding of the role of the psoas muscle and its impact on lumbopelvic stability may improve the student and the individuals and the clinician manage the clinical problems suffering from the lower back. So, here we will discuss specifically its anatomy and some part of the biomechanics and its functions. Clinical presentation, psoas major dysfunctions also. The psoas major is a long fusiform muscle placed on the side of the lumbar region of the vertebral column and brim of the lesser pelvis. It arises from the anterior surface of the bases borders. It arises from the anterior surface of the base borders of the transverse process of all the lumbar vertebrae from the sides of the bodies and the corresponding intervertebral fibrocartilage of the last thoracic and all the lumbar vertebrae by 5 sleeves, each of which is attached to the adjacent upper and lower margins of the two vertebrae and to the intervertebral fibrocartilage. From a series of tendinous arches which extend across the constricted part of the bodies of the lumbar vertebrae between the previous sleeves. The lumbar arteries and veins and filaments from the sympathetic trunk pass beneath these tendinous arches. The muscles proceeds downward across the brim of the lesser pelvis and diminishing gradually in size passes beneath the inguinal ligament and in front of the capsule of the hip joint and ends in a tendinous form. So the tendon receives nearly whole of the fibers of the iliacus and is inserted into the lesser trochanter of the femur. A large bursa which may communicate with the cavity of the hip joint separates the tendon from the pubis and the capsule of the joint. Sometimes there is the presence of the psoas minor muscle, that is also a long slender muscle placed in front of the psoas major muscle. It arises from the sides of the bodies of the 12th thoracic and the first lumbar vertebra and from the fibrocartilage between them. It ends in a long flat tendon which is inserted into the pectineal line and iliopectineal eminence and by its lateral border into the iliac fascia. This muscle is not widely present in some patients or in some subjects you will find the psoas minor muscle. The iliacus is also comes along with the psoas major and psoas minor muscle which attaches to the lesser trochanter. So here we will just give uh, some brief idea about the iliacus also. So this iliacus which is a flat and triangular muscle, fills the iliac fossa. It arises from the upper two-third part of the fossa and from the inner lip of the iliac crest. From the anterior sacroiliac and iliolumbar ligaments and base of the sacrum in front, it reaches as far as the anterior superior and anterior inferior iliac spine and the notch between them. The fibers converge to be inserted into the lateral side of the tendon of the psoas major, some of them being prolonged onto the body of the femur for about 2.5 cm below and in front of the lesser trochanter. Is the largest muscle. In cross section, you can see here in this diagram, at the lower level of the lumbar spine, it has fibrous attachment to the anterior aspect of all lumbar transverse process and to the anteromedial aspect of the all lumbar discs and adjoining bodies with the exception of the L5S1 disc. For the relative positions on the spine, the attachment on the transverse process are named the posterior attachment and those on the disc and bodies are called the anterior attachments. These attachments constitute the individual fascicles. The fascicles of the psoas major are approximately similar in length throughout the lumbar spine and have a unipinnate fiber orientation muscle. Muscle fiber length within the anterior fascicles ranges from 3 to 8 cm and 3 to 5 cm in the posterior fascicles. The fascicles are oriented inferolaterally and come together as a common tendon which descends over the pelvic brim and shares a common insertion with the iliacus muscle on the lesser trochanter of the femur. The fascial relation of the psoas major to the surrounding tissues, the medial arcuate ligament is a continuation of the superior psoas fascia and that continues superiorly to the diaphragm. The right and the left cross constitute the spinal attachment of the diaphragm. They attach to the anterolateral component of the upper three lumbar vertebral bodies. The cross and their fascia overlap the psoas major and appear to be continuous with the muscles until they come more anterior and blend with the anterior longitudinal ligament. As the psoas descends, its inferomedial fascia becomes thick at its inferior portion and is continuous with the pelvic floor fascia. This forms a link with the conjoint tendon, transverse abdominis and the internal oblique. As the psoas major courses over the pelvic brim, the fascia of the posterior fascicles attach firmly to the pelvic brim. So, if you will see the function and the major biomechanics of the psoas major muscle, the function of the psoas major muscle, the psoas major could not be separated from the iliacus with regards to their collective action of a hip joint flexor. Some authors says that psoas major in major muscle played a significant role in advancing the limb while walking and in controlling deviation of the trunk when sitting. This muscle may play with respect to the lumbar spine stability and movement. This role includes psoas major being a flexor of the lumbar spine on the pelvis, a lateral flexor of the lumbar spine, a stabilizer of the lumbar spine, stabilizer of the hip, power source for bipedal walking and running, and controller of the lumbar lordosis when supporting difficult lumbar loads. The psoas the psoas major works physically as an erector of the lumbar vertebral column as well as the stabilizer of the femoral head into the acetabulum from 0 to 15 degree, exerting decreased stabilizing action in contrast to maintaining the erector action, that is from 15 degree to 45 degree, and also it is an effective flexor of the lower extremity at the hip joint from 45 degree to 60 degree. There is growing evidence that demonstrate how these muscles coordinate their activity to stabilize the spine. For example, transversus abdominis has been shown to co-contract with the diaphragm, the pelvic floor and the deep fibers of the lumbar multifidus. So according to this model, the psoas major is ideally located to assist in a stabilizing role. Psoas major has intimate anatomical attachments to the diaphragm and the pelvic floor. This unique anatomical location allows the psoas major to act as a link between these structures and may help in maintaining the stability of the lumbar cylinder mechanism. This can be thought of conceptually as a supporting rod in the middle of the cylinder. Early biomechanical literature suggested that the psoas major might aid the stabilization of the lumbar spine through its large potential to generate compressive forces which would result in increased spinal stiffness. So myofascial pain from or myofasciopathy of the psoas major muscle will often present as anterior hip or lower back pain. So referral areas include the anterior thigh. The psoas major muscle can be considered as a pain source in athletes, office workers or anyone who spends much of their day sitting. Psoas major myofascial pain is thought to be the prevalent in certain sports including the soccer, dance and hockey. Myofascial psoas major pain is different from that of psoas tendinitis, psoas bursitis or coxae. So it should be noted that the snapping or popping of coxae produces pain at the anterior aspect of the groin, and the patient can often reproduce the snap or pop themselves. So when you will do the physical examination, postural analysis may indicate an increased lumbar lordosis and posterior pelvic tilt. Gait analysis may reveal a certain stride on the affected side, and conducting a functional squat test may cause pain or indicate hip flexor weakness. Strength testing of psoas major can be conducted in numerous ways. Generally, the patient will be in supine lying position as long as the patient resists the examiner's attempt to extend the hip. Assessment of active and passive hip ranges of motion is important, particularly active flexion and extension and passive extension generally performed with the patient in prone lying position. Palpation can be conducted with the patient either supine or side lying position, but should likely involve the examiner flexing the hip to 30 degree and palpating the psoas major muscle medial to the anterior superior iliac spine and deeper into the abdomen. When the examiner feels they are palpating the psoas major muscle, having the patient flex their hip against the resistance should allow the examiner to feel the psoas major contract. The examiner must consider patient comfort when palpating the psoas major, as it may be extremely tender, ticklish or more invasive than the patient's comfort level allows. Still, reproduction of the patient's pain on palpation of the psoas major muscle with tightness and tenderness are strong indicators of the psoas major myofascial. The psoas major is supplied by branches of the second and third lumbar nerve, the psoas minor by a branch of the first lumbar nerve, and the iliacus by branches of the second and third lumbar nerve through the femoral nerve. The psoas major is innervated by direct branches of the anterior rami of the lumbar plexus at the level of L1 to L3, while the iliacus is innervated by the femoral nerve, which is composed of the nerves from the anterior rami of L2 to L4. So, if you will see the normal clinical significance of this psoas major muscle, it is a typical posture muscle dominated by slow twitch red type uh, muscle, mainly the type 1 fibers, since it originates from the lumbar vertebrae and then inserts into the femur. Any structure from the lumbar spine to the femur can be affected directly. A short and tight iliopsoas often presents as externally rotated legs and feet. It can cause pain in the low or mid back, in the sacroiliac joint, at the hip, at the groin, thigh, knee, or any combination. The iliopsoas gets innervation from the L2 to L4 nerve roots of the lumbar plexus, which also send branches to the superficial lumbar muscles. The femoral nerve passes through the muscle and innervates the quadriceps, pectineus, and sartorius muscles. It also comprises the intermediate femoral cutaneous and medial femoral cutaneous nerves, which are responsible for the sensation over the anterior and medial aspect of the thigh, medial shin, and arch of the foot nerves. The obturator nerve also passes through the muscle, which is responsible for the sensory innervation of the skin of the medial aspect of the thigh and motor innervation of the adductor muscles of the lower extremity. And sometimes the pectineus, any of these innervated structures also can be affected. Separation of the psoas major muscle. Psoas measures triangular separation on every side of the body of L5 vertebra with all the apex directed upward. It is bounded medially by the body of L5 vertebra, laterally by the medial border of the psoas major, and inferiorly by the ala of the sacrum. The apex is composed by the junction of the psoas and the body of L5 vertebra. The floor posterior wall is composed by the transfer process of L5 vertebra and iliolumbar ligament. It includes four structures. From medial to lateral sides. These are sympathetic trunk, lumbosacral trunk, iliolumbar artery, and obturator nerve. So all these structures remain in a triangular form. That triangular form is known as your lumbosacral triangle of Mercilli.